Hello everyone. So today we are going to discuss a very important commonly asked question for your prof exam, that is tuberculosis. So I would like to discuss the tuberculosis with the help of a case scenario. A man in his 40s is referred to a chest physician with a cough productive of sputum and fever. Chest X-ray indicate bilateral pneumonia with apical involvement. Sputum smear reveals acid-alcohol-fast bacilli. Acid-fast bacilli. His physician considers that TB is the most likely clinical diagnosis. So this is one of the very typical case scenarios. So from the history itself, they are telling that the patient is having tuberculosis. Let me tell a somewhat a different question, which is most commonly given in your exams. That is this. A 48-year-old male comes with complaints of loss of weight, loss of appetite, cough with blood tinged sputum. See, actually in tuberculosis there won't be hemoptysis. Okay, hemoptysis most preferably we can say, what is hemoptysis? That is coughing up of blood. This blood may be either a blood tinged sputum, blood streaked sputum, or frank blood. Fine, frank blood you will get in bronchogenic carcinoma. Okay, so here you usually get a blood tinged sputum, and on examination there was altered breath sounds. That's it, simple. Okay, they won't give a much elaborate. What is your diagnosis? What is the role of cell mediated immunity in this infection? What are the various clinical stages, and what is the role of skin sensitivity test in this condition? So from this history, when this very vague history, you have to find the diagnosis as it is a case of tuberculosis. Fine? Yes. Okay. So actually, what is this tuberculosis caused by? Mycobacterium tuberculosis. You know already it is a slender aerobic rods. Okay, and remember, mycobacterium has a very important component in its cell wall. That is what we call it as mycolic acid, and it is because of this mycolic acid, mycobacterium is acid fast. Okay, yes. And remember, they are weakly gram positive. I'm not going to explain in detail about the microbiological characteristics of the organism that you are going to read from microbiology. Today my discussion will be purely based on the pathology. Fine? Yes. So remember, as India is known as the TB capital. India is the tuberculosis capital, and remember, tuberculosis is the killer. Am I right? Yes. So in India, we have the tuberculosis is one of the it is the most common cause of any chronic pulmonary disease. Fine? Yes, it is a chronic disease caused by mycobacterium tuberculosis. Remember, the source of transmission is humans with active tuberculosis who release mycobacterium present in the sputum. Okay? Yes. And even mycobacterium bovis, which is not that much common in India, but in abroad it is common in other countries, which is spread through milk. Okay? Yes. So coming into epidemiology, I have already told you that tuberculosis is one of the most common cause of chronic pulmonary disease as far as a developing country like India is concerned. Fine? Yes. And most infections are occurred by person-to-person transmission or airborne organisms. Very, very important. Okay. So what to say? See, in most of the cases, okay, in tuberculosis, we have some terminologies called as latent infection or active infection. And remember, there is only one important sign which is say that the patient is having active infection. That is nothing else but a fibrocalcific pulmonary nodule. It has been asked as an MCQ years back. That's why I am pointing out that fibrocalcific pulmonary nodule. Okay, it is the only evidence of an infection, active infection. Fine. And remember, I have already told you that we have something called as MAN2 test, also called as tuberculin test, where we will be injecting a purified protein derivative, okay, and intradermally, am I right? Intradermally, and we will be observing the induration. And if there is any palpable, okay, any visible and palpable induration that peaks in any 48 to 72 hours, that indicates that the cell-mediated immunity. Okay, so this is actually this MAN2 test is going to assess the cell-mediated immunity. It cannot say that whether the patient is having an active infection. It can say only whether the patient is having any latent infection. Okay, yes. And we have some false negative reaction, which because in false negative cases occurs in case of Hodgkin's lymphoma, sarcoidosis, immunosuppression, and false positive reaction may result when the patient has been already getting BCG, Bacillus calmette-guerin. So BCG vaccination, we all have BCG vaccination. Am I right? In the left upper arm, we can see a BCG scar. So this is because of the BCG vaccination, and this may give false positive reaction. Okay, please just remember this important point. Yes. Here comes the most important aspect of our discussion. What is the pathogenesis? See, even I, you, each one of us is being exposed to the tuberculosis bacteria. When you go for TB or thoracic medicine posting, you will be exposed to tuberculosis bacteria, no doubt. Fine. That is why we are advised to wear a 95 mask. But the outcome of the infection, it depends upon the immunity, the cell-mediated immunity of the host. Okay, that is the first most important thing. If the cell-mediated immunity is intact, then it is going to produce a spectrum of infection. And if it is immunocompromised, it is going to produce another spectrum of infection. Fine. Yes. So let us discuss in sequence what steps of infection by Mycobacterium tuberculosis. First, I am telling first of all in gist about actually what is the pathogenesis. See, there will be initial infection of macrophages. See, actually the Mycobacterium tuberculosis is going to attack the macrophages. So it is going to protect itself from getting attacked by the macrophages. It is because it is going to target the macrophages only. You know, in HIV, why we are not able to find a proper cure for HIV, because HIV is directly targeting at our immunity. Fine. Yes. Then following by that, after infecting the macrophages, there will be a T helper 1 response that is responsible for the tissue damage. So actually what is the concept is, the mycobacterial antigens is going to use our own immune system to destroy ourselves. That is the simple concept. Fine. The first step is entry into macrophages. Mycobacterium tuberculosis enter the macrophages with using some mannose binding lectin receptor and CR3 receptor. The name of the receptor has been asked multiple times. Then within the macrophages, it undergo replication. Remember, macrophages will usually digest the foreign particle, but the Mycobacterium tuberculosis will inhibit the maturation of phagosome. It will inhibit the formation of phagolysosome. So there will be unchecked proliferation of the Mycobacterium within the macrophages, and as a result, what will happen? Yes, what will happen? The macrophage will serve as a Mycobacterium tuberculosis factory. Fine? Yes. And the bacterium will block this phagolysosome formation by mainly inhibiting the calcium signals, because you know calcium is one of the most important protein which is required for what we call as receptor mediated endocytosis as well as phagocytosis. Fine? Yes. Okay. So, during the earliest stage of primary tuberculosis means the tuberculosis which is going to affect the lung parenchyma. Even the pleura also we call it as primary tuberculosis. Fine? Yes. So, that too within the less than 3 weeks, we can see the bacteria undergoing proliferation within the pulmonary alveolar macrophages. So, the first step, second step, coming into the third step. So, Mycobacterium tuberculosis, they are recognized by how they are going to get recognized. They are recognized by some important toll-like receptor, mainly it is TLR2. Okay, yes. So, it is not just a third step. I am just told that how it is being recognized by immune system. We have some toll-like receptor 2. So, as you can see in this picture, so before the activation of what will happen, cell-mediated immunity. So before the cell-mediated immunity is active, so it mainly binds to what we call the C3b receptors. Fine. Then it will prevent the phagolysosome formation. Am I right? And finally, there will be unchecked bacterial proliferation and the bacterial proliferation, and there will be bacteremia with the seeding of the multiple sites. Then what will happen? Then comes the cell-mediated immunity comes into action. Once the cell-mediated immunity, because I told you, pulmonary alveolar macrophages serve as a factory for Mycobacterium tuberculosis. The alveolar macrophages will be releasing interleukin 12, which will further stimulate the T helper 1 cells. This T helper 1 response is responsible for the tuberculin positivity. This T helper 1 cells will further produce interferon gamma, which is, gamma interferon. We have two pathways of macrophage activation, classical and alternate pathway of macrophage activation. Here the gamma interferon is going to causes the activation of macrophages, and these macrophages undergo some conformational changes, multinucleation. Yes, we call it as granuloma. So here I am making my point very clear. Only and only if the cell-mediated immunity is intact, we will be having granuloma formation. Suppose immunocompromised, HIV, chronic steroid therapy, what happened? There is no active cell-mediated immunity. In such a case, granuloma formation does not take place. Here comes a very important, it's a very simple basic MCQ question that will be asked. Okay, in which of the following condition there won't be granuloma formation? Okay, option A will be TB. Yes, TB has granuloma. Option B, you will be having sarcoidosis. Of course, sarcoidosis is granuloma. C, there will be cat scratch disease. Cat scratch disease have granuloma. Option D, TB in HIV. Remember, TB in HIV don't have granuloma because cell-mediated immunity is not intact. Okay, why, how the granuloma is formed. Fine. Yes. So interleukin 12, interferon gamma. Okay, interferon gamma will produces all those things. Granulomatous inflammation, epithelial cells, Langerhans giant cell. All the same stories we have already discussed in granulomatous type of inflammation chapter, inflammation. Fine? Yes. So even though T helper 1 cells are most importantly discussed in the pathogenesis of Mycobacterium tuberculosis, the role of other cells like gamma delta T cells, okay, is also well explained, because this gamma delta T cells has also known to produce what we call it as interferon gamma. Fine? Yes. So whenever there is any, so there are some host susceptibility. Why everyone, I am exposing to tuberculosis bacteria, okay, but I am not getting tuberculosis. So there will be some genetic predisposition. Whenever there is a deficiency in interleukin 12 pathway, again this has been asked as an MCQ in PG entrance exam, which of the following interleukin deficiency has been associated with increased risk of acquiring tuberculosis infection? Answer is interleukin 12. Okay, as well as there are what TLR2 polymorphism, HLA interferon gamma polymorphism has been also found to be associated with increased risk of getting tuberculosis. So in summary, what I have to tell mainly it is T helper 1 cells, gamma interferon, macrophages activation, then finally granuloma formation. Fine? Yes. So this is the important. So if you draw these two pictures itself, it is more than enough. VIP picture this is. Okay? Yes. So once this is done, let us now discuss about what is primary tuberculosis and secondary tuberculosis. So primary tuberculosis means the tuberculosis which occurs in a non-immune host, and secondary tuberculosis is which occurs in the host who is immune to Mycobacterium tuberculosis. Simple. For example, I am now healthy. I am going to talk with a TB patient. Daily I am going and talking 7 days. So after that I tested positive for TB. Yes, TB test positive. That means I am not immune to, I have not been exposed to tuberculosis, right? But I developed. That is primary. I have already exposed, fine, but I don't get TB. Again, I am exposing, I am getting TB. That is secondary tuberculosis. Simple. So, the primary tuberculosis is the form of disease that develops in a previously unexposed, unsensitized person. Both words are important. Unexposed, unsensitized person. Fine? Yes. And remember, the tuberculosis, that is the primary tuberculosis, is usually progressive. Okay? Progressive. Okay? Progressive. And remember, the progressive primary tuberculosis, it will mimic an acute bacterial pneumonia. Okay, with lobar consolidation, hilar adenopathy, pleural effusion. Pleural effusion, remember this is like a 3 important hallmark features of primary tuberculosis. Whereas in case of secondary tuberculosis, there will be what we call it as cavitation and caseation. Okay, this caseation, necrosis and all those in the lungs we are seeing mainly in secondary tuberculosis. There will be cavitation. Okay, in the lungs, we will be getting some openings, cavitation. That is all features of secondary tuberculosis. Here comes the question: which of the following are not found in primary tuberculosis? Definitely cavitation is a hallmark feature of secondary tuberculosis. So secondary tuberculosis is the pattern of disease which arises in a previously sensitized host, and I told it mainly involves the apical lobe. Okay, yes, mainly involves the secondary tuberculosis mainly involves the apical lobe. Okay, why? Not only secondary tuberculosis. Tuberculosis means generally apical lobe. Why? Because high oxygen content. Okay, because it's on a obligate aerobe or Mycobacterium tuberculosis, so it can survive only in regions with a very high oxygen tension. And remember, the secondary pulmonary tuberculosis classically involves the apex of the upper lobe of one or the both legs. Fine. And but in case of primary tuberculosis, there will be marked lymphadenopathy. Okay, cervical lymphadenopathy. That means cervical lymph node enlargement will be seen. Whereas in secondary tuberculosis, it is not that much seen. And cavitation, I told you, cavitation is a classical feature of secondary form. Okay. Then the clinical features, I told you what: evening rise of temperature, low grade remittent type of fever, anorexia, malaise, weight loss, fever, night sweats, all those things. Fine? Yes. And radiographic findings, you can see consolidation or cavitation depending upon whether it is primary or secondary. You can do acid fast staining and sputum culture. All those things you please, LJ medium is the culture medium. We have that is the solid medium. We have Middlebrook, that is the liquid medium. Please learn all those microbiological findings, diagnosis techniques, everything. It's in depth. It is given in Apurva Shastri. You can read from that. Fine. So this is the very important table which represents the history of the tuberculosis. See. Okay, initially there may be a primary infection which will form some mild caseation, that is we call it as primary complex. Okay, and this caseation may undergo healing. Okay, healing. So this finally, as a result of healing, there will be scar formation. Sometimes this caseation, it won't heal properly and it will remain, the organism will remain dormant. That is what we call as latent TB. And when the immunity is suppressed, this latent TB undergo reactivation to form secondary tuberculosis. Or secondary tuberculosis can form directly as a result of reinfection. I told you, secondary TB means already the patient is exposed or sensitized. Or the primary TB may progress. I told you, the primary tuberculosis is always progressive, which may undergo massive dissemination to form miliary tuberculosis. Why it is miliary? Because in other organs, when this tuberculosis, it is characterized by millet-like appearance in spleen, liver and all. And the secondary tuberculosis can again progress to progressive secondary TB and again miliary TB. And remember, what is that? Cavitation and destructive lesions are characteristic features of caseation is found in both. But in primary TB, only mild caseation is there. There is very prominent caseation along with the cavitation is the characteristic feature of our secondary tuberculosis. Fine. Yes. So coming into the morphology, yes. So this is what we are going to discuss as far as path is concerned. In primary tuberculosis, I told you, mainly the upper part of lower lobe or lower part of the upper lobe. Fine, it is the most commonly involved. Okay, and there will be some 1 to 1.5 centimeter gray white infarct with the consolidation. This is what we call it as Gons focus. Okay, Gons focus. And remember, whenever there is Gons focus along with the lymph node enlargement, this is what we call it as Gons complex. So what is Gons focus? Lower part of the upper lobe, upper part of the lower lobe. Consolidation, Gons focus. Gons focus along with the lymph node enlargement, we call it as Gons complex. This Gons complex, lymph node. So it undergoes progressive calcification, and this progressive calcified Gons complex, we call it as Ranke's complex. What we call it as Ranke's complex. So what is Gons focus? Consolidation of the apical lobe. Consolidation with the lymph node enlargement, Gons complex. Gons complex undergo calcification, Ranke's complex. Very simple, very simple. And histologically, you will write much better than me. You will know what is granuloma, what is activated macrophages, what is the structure of a granuloma, what is Langerhans giant cell, what is the shape of the nucleus. It is horseshoe-shaped nucleus, Langerhans giant cell. Fine? Yes. And remember, this is only present in immunocompetent host. In immunocompromised host, in immunocompromised, I am writing IZ. See, this is what you are seeing now. This is the calcified Ranke's complex. Okay, what you are going to see is the Gons complex, and this undergo calcification to forms the Ranke's complex, mainly in the apical lobe, upper part of lower lobe, lower part of upper lobe. Fine, yes. And secondary tuberculosis, I told you, there will be small consolidation, but mainly, see, these are all, you can see the caseating granuloma, you can see the horseshoe-shaped Langerhans giant cell. This is the AFB. See, this is the classical horseshoe-shaped, nucleus. Langerhans giant cell. See, secondary pulmonary tuberculosis, again we will have cavitation. You can see opening. You can see big openings. This is cavitation, secondary tuberculosis. Okay, yes. So you have to write separately the morphology of primary and secondary tuberculosis. In secondary tuberculosis, main point you have to recognize is there will be gray, white, yellow in color, and it is very usually it won't be that much progressive. There will be characteristic cavitation. Fine. Yes. In progressive pulmonary TB, that is what we call as miliary tuberculosis. What is miliary tuberculosis? There will be microscopic small visible focus of consolidation, okay, which is seen in the lung parenchyma. It is also seen in case of spleen, also seen in liver. It looks like a millet seeds. That is why it is called as a miliary tuberculosis. Actually, it is nothing else but this TB, when it enter into the circulation, okay, it will reach the other organs, okay, spleen and liver, okay, and it undergo deposition there, and there it forms some small multiple focus, numerous focus, small focus of consolidation. That is what we call as miliary tuberculosis. I told you there will be pleural effusion in case of tuberculosis. Pleural effusion, consolidation, okay, caseation, cavitation, all these are features of tuberculosis. Fine? Yes. So this is what we call as pulmonary tuberculosis, because so far we have discussed only about the tuberculosis which has affected only the lung parenchyma and the pleura. Suppose it may also affect the endobronchial, endotracheal and laryngeal tuberculosis. Even it may go for the systemic circulation. Fine? Yes. And we have something called as pot spine. Pot spine has been asked as a short answer or MCQ question frequently. What is pot spine? That means the tuberculosis, in disseminated tuberculosis. See, this tuberculosis can affect almost all organs. In kidney it may cause renal tuberculosis. In meninges it may cause tuberculous meningitis, which is very fatal, then osteomyelitis, salpingitis. Okay, all these you have to remember. And in vertebra, we call it a spot spine. Okay, I think it is in 17th century. A person, okay, what is it? I don't remember his full name. It is Fisley Pott. Okay, he actually has described this. Okay, there will be cold abscess formation. Why it is called as cold abscess? In tuberculosis, have characteristic of cold abscess, because there won't be the usual signs of inflammation will be completely absent in case of tuberculous abscess. That is why it is called as a cold abscess. This cold abscess is seen in the vertebra, most commonly in the lumbar vertebra. Okay, lumbar vertebra. That is why it is called as cold abscess. Okay, cold abscess, psoas, major abscess, everything will develop. So that tuberculosis of the spine. Okay, what is Pott's disease? Pott's disease is nothing else but TB spine. Okay, TB spine is called as Pott's disease, associated with the cold abscess. Okay, yes. Then lymphadenitis. See, I don't know lymphadenitis. That is very, very important. Cervical lymphadenitis is one of the most common clinical manifestation of a TB. Okay, yes. So in extrapulmonary tuberculosis, what do you mean by extrapulmonary tuberculosis? Other than the lung parenchyma and pleura, okay, there will be what lymph node enlargement, granulomatous lymphadenitis, all these. That is what we call it. Lymphadenitis is one of the most common clinical manifestations. So the patient, okay, a chronic smoker, he may comes with the OPD with the cervical lymph node enlargement. That indirectly indicates that he may be having TB. Okay, then intestinal tuberculosis. Remember, it is most common in which region of the intestine? Terminal ileum. What is the reason? It has Peyer's patches. That's the reason. Fine. Yes. And okay, so these are some of the important points. So when the tuberculosis is asked, what are the headings or how you are going to write? First, you are going to write about mycobacterium. Then you will be writing about epidemiology. Then you will be writing about the pathogenesis. We have the various steps. Please remember this picture. Okay. Then you will be writing about the clinical features, primary, secondary. What are the difference between these two in the clinical features? I told you, cavitation, caseation, all those stuffs. Then you are coming to write about this. Okay, what is the sequelae of the pulmonary tuberculosis? Then you will be writing morphology under that primary, Gons focus, Gons complex, Ranki's complex, then caseating granulomas, granulomatous inflammation. Secondary TB, you will be writing more about cavitation. Then you will be writing about progressive TB, that is a miliary tuberculosis. Then you will be writing about what lymphadenitis. You will be writing about other manifestations, that is what happens in the kidney, all those. Then you will write about miliary tuberculosis, the millet seed like things. Then finally a word about lymphadenitis and intestinal tuberculosis. And finally go about the treatment, read about the anti-tubercular regimen, the HRZD regimen and HRE regimen, intensive phase, continuous phase, everything is mentioned in pharmacology. And please go about in depth what are the false positive and false negative results for in MAN2 test. Okay, that is purified protein derivative tuberculin sensitivity test. Then what are the molecular diagnostic methods, recent molecular diagnostic method which are available for the diagnosis of TB. TB is a very vast topic. As far as path is concerned, this much is important. We have Gons focus, Gons complex, okay, Ranki's complex, all those things. And I want to tell something about some other lesions. Okay, some other lesions. That means the lesions of other conditions, lesions of other organs. Okay, like we have discussed, Gons focus, Gons complex. Okay, like that. I want to discuss about some other things that is not mentioned in Robbins. Okay, just for MCQ purpose. So I have already told you what are the important focus. First one is I told you what is Gons focus. What is Gons focus? Second thing, I have told you what is Gons complex. Third thing, I have told you what is the Ranki's complex. Fourth thing I am going to mention is what is rich focus. Rich's focus. Rich's focus means, okay, rich's focus means the tuberculous granuloma which is seen in brain cortex. Brain cortex. Then fifth one, Wiegert's focus. Wiegert's focus. Wiegert's focus, it is mainly seen in pulmonary vein. Pulmonary vein. Then sixth one, Simon's focus. Simon's focus. Where you will see Simon's focus in liver. Then what is pulse lesion? PUHL''S. pulse lesion. Lesion in the lung apex. Apex of lung, that is supraclavicular. Supraclavicular. Then we have Asman's focus. Asman's focus. Asman's focus is nothing else but infraclavicular lesions. Just for MCQ purpose. Infraclavicular lesions. I have told you Ghon's complex. Remember, Ghon's complex is seen below the clavicle. Ghon's complex seen below the clavicle. Ranki's complex, fibrosis and calcification of Ghon's complex. Fine? Yes. So, remember just a few points, extra points. In secondary tuberculosis, we have the hallmark features are cavitation and pulmonary fibrosis. Pulmonary fibrosis. Fine. Then miliary TB. Miliary TB is associated with poor prognosis. Miliary TB is associated with poor prognosis. Fine? Yes. Then just remember an extra point. We have something called as congenital TB. Congenital tuberculosis. That means during intrauterine life or through birth canal, the infection will be acquired by the baby. That is called as congenital tuberculosis. Because of some hematogenous infection via umbilical vein, fetal aspiration via infected amniotic fluid, fetal ingestion of infected amniotic fluid. Okay, and the most common site for the primary, that is the, in congenital tuberculosis. In congenital tuberculosis, the most common site for tuberculosis is liver. Liver, remember, liver, not lung. Most common site for primary TB. Primary TB, and we have a criteria to diagnose this. This is called as Cantwell's revised criteria. What is the name of this criteria called as? Cantwell's revised criteria for diagnosis of congenital tuberculosis. Okay, just remember this very important point. Fine. So I have discussed almost all the extra things, everything. Then if they ask you what is the virulence factor, virulence factor of for Mycobacterium tuberculosis, the answer is cod factor. The answer is cod factor. Okay, cod factor. Fine. Yes. And remember another most important point: tuberculosis is also known as Koch's disease, or because what it is, Koch's bacilli, am I right? Yes, Koch's disease. Fine. Yes. So everything we have discussed. So tuberculosis is a very common question, clinically very important. Please go through all these extra points. So hope this session has been useful for all. Thank you.